So I suppose this would be installment number 2 of our mobility lecture. We were able to get through all the way through RA, I think. Let me find the place where we need to start. Here we go. So we're going to start our conversation today talking about some musculoskeletal injuries that our patients might experience. Now, some of these might occur in the outpatient setting much more frequently than in the inpatient setting. For example, the first thing that we'll talk about being sprains and strains, we'll just kind of quickly touch on that. But regardless really of what the musculoskeletal injury is, one word we're going to keep saying is neurovascular. When we have, if you think of the anatomy of just kind of our body, our musculoskeletal system, it's comprised of muscles and bones, thus the name there. So when something happens, some kind of injury happens to those muscles or bones, because our immune system does what it does by providing protective inflammation, it can potentially cause problems to other structures that are surrounding those tissues being muscles and bones. So if you think about something even as simple as your finger, for example. If you look at your finger, you know that you have a bone inside of there, as well as muscle, ligaments, tendons, blood vessels, adipose tissue, skin, all of these things that are inside of there, and nerves. That's another thing. And so when we have an injury, maybe not necessarily to a blood vessel or a nerve or something like that, we can still have effects to those structures because of the injury to the bone or the muscle. And that's what we're going to talk about when we kind of start talking about this word neurovascular. So you'll just kind of hear this a lot, something important that you need to understand. Musculoskeletal system, it provides movement, it provides, structure to our body, and it is definitely prone to injury. We see lots and lots of injuries in the patient populations that we care for, things like fractures, things like sprains and strains, stuff like that. They'll come into outpatient settings sometimes, or maybe even do a little bit of self-care at home, or if more severe, maybe they will be seen in an urgent care or emergency situation. These types of injuries often have negative effects on our patients' mobility, as well as their sensation or their ability to feel. And overall, that can impact the performance of their normal everyday living, kind of day-to-day life. If you've ever experienced some kind of musculoskeletal injury, you might be able to kind of identify with that a little bit. Different times, perhaps, maybe that you had to have assistance from other people, or you were limited in your ability, to just do normal things that you were used to doing all the time, and then maybe weren't so much after injury. Sprains and strains are very similar. Really, the only difference is the actual location of the injury. They can be range from mild to moderate, but they're one of the most frequently occurring orthopedic injuries. We see a lot of people come in to urgent care and to emergent care and to their providers. Lots of sports injuries or athletic injuries are oftentimes sprains and strains. I often, at least personally, whenever I hear of like a sprain or a strain, I immediately think of an ankle. I think that's a pretty common joint in which this type of injury occurs, especially with things like, basketball, soccer, ice skating, running. We have that opportunity to kind of twist and injure that supportive structure there. Notice that really the only difference between a sprain and a strain is the actual tissue that is affected there. So a sprain is when we have damage to a ligament, whereas a strain is where we have damage to a tendon and muscle. We may not always be able to tell like externally when we look at a patient whether it's a sprain or a strain. But it doesn't really matter in the sense that it's not really going to make a difference in the way that our initial reaction or response to that injury is going to happen. This just kind of explains, what happens when someone experiences a sprain or a strain. And essentially, what's going on is those connective tissues that help to provide structure to a joint become damaged. They get stretched out. I'm stressed out, stretched out. And then it makes the joint overall weak. And this happens because there's some sort of force that's applied to that joint. And then it's just not able to perform its normal function. Now, between this slide and the next slide, they're going to look very, very similar, again, because strains and sprains are indeed very, very similar. So I'm not going to spend a lot of time on both of them, but just know here that there's a difference, kind of a progression of a first degree strain, a second degree strain, and a third degree strain. And you'll see that same sort of progression when we look at sprains. So the lower the degree, the less the effects related to that injury. So with a first degree strain, this is just going to be mild stretching of that tissue. There might be some swelling present, or it might be tender, maybe a little bit of muscle spasm. You may or may not really notice a lot of loss of function. Maybe when the injury first occurs, there may be a little bit of inability to bear some weight, and then you kind of walk it off and you start to feel a little bit better. That would be classified as that first degree injury. With a second degree injury, we're going to start to see some beginnings of tearing of the tissue. And when that happens, we're going to lose the ability to bear weight on that joint, along with swelling and tenderness and muscle spasms, which might be more significant. You may also see ecchymosis, which is just kind of like bruising. It's just a little bit more extensive and sort of spread out is sort of the way that I like to look at that. But you'll notice that the symptoms that are going to be present, or the clinical manifestations, what you might see on your assessment between a first and second degree strain, are similar, but it's just going to be more severe as you get to that more significant injury with the ecchymosis and the loss of the ability to bear weight on that joint. Now, with a third degree strain, we're going to have severe stretching, tearing of the tissue. We may even have rupturing of things like muscles or tendons. So the pain is going to be much more significant, as well as the swelling and the loss of function. When something is significant as a third degree injury, a sprain or strain occurs, there might be some concern about a fracture, and so it's likely that we'll look at an x-ray just to make sure there isn't a bony injury. Sometimes when a third degree injury occurs, a patient might experience what is called an avulsion fracture, which is basically when the force that led to that injury caused this tearing and stretching and extensive damage to these tendons and muscles, that it kind of just like ripped off a piece of the bone with it through that injury. Now, x-rays are actually really good for looking for bony injuries. They can show some soft tissue swelling, but they're not really going to tell us what exactly the injury to things like tendons or ligaments or muscles are. To find out the exact extensiveness of the injury, then we would have to get something that's going to be able to look at that type of tissue like an MRI. So when you look at this slide where it kind of lays out sprains, you'll notice that it's laid out pretty much the same. Again, the difference between sprains and strains is the tissue that's involved in the injury. So with the first degree, it's pretty mild. There's some tenderness, maybe some swelling. With the second degree, we have a little bit more significance to those symptoms, and the joint is more unstable, and so there may be some loss of function or ability to bear weight. And then again, with that third degree, we have completely ruptured or torn the tissue and may see avulsion present, and just really severe pain and inability to move that joint or bear weight on that joint. So pretty much the same progression as a strain. It's just that with sprains, we're looking at damage to the ligaments as opposed to tendons or muscles. So these types of injuries can be quite painful. They can see, swelling, sometimes discoloration if there's ecchymosis or that kind of thing. Bleeding into the joint can occur. That can cause more pain. Diminished strength of the joint, range of motion is limited. So those are the things that you're going to see on your assessment of a patient with a something like a sprain or a strain. If we're trying to make sure that there's no complications because of that injury, and this is where I'm going to start with that word of the day, neurovascular. Swelling is good. If we pause and think for a moment back to the immune system and how the inflammatory response is part of the immune system, and it brings an increase of blood flow to the damaged area, which allows for different kinds of white blood cells to infiltrate the area. It provides cushion to the area, limits the movement. All of those things are in a body's attempt to protect the area that has been injured. However, there can be a point where that balance is tipped and it's no longer beneficial if that swelling and edema is allowed to continue unchecked. And what can happen is all of the other structures that are within that space can start to be negatively affected by the excessive inflammation. Things like blood vessels and nerves in particular, they can become compressed. And when that happens, then we start to see signs of alteration in sensation and alteration in perfusion. Because if nerves are compressed, then we're going to see changes in the ability to feel distal to that injury, or distal would be like, like if I'm thinking about the ankle, would be below, I guess that would be a good word, away from the injury. Anyway, and if I have decreased blood flow because of compression of blood vessels, then perfusion distal to that injury is going to be compromised, and we're going to see changes in our perfusion. So with all of these types of musculoskeletal injuries that we're talking about, we're looking for what is one way to refer to this is assessing for the 6 P's of our neurovascular assessment. And those P's are pain, pressure, paralysis, paresthesia, pulselessness, and what's the last one? Hold on, I'll get it. Pain, pressure, paralysis, paresthesia, pulselessness, and I always can remember 5 off the top of my head, but then I can't remember the 6th. Pallor. That's the other one. I knew it would come to me. Pallor. Those were in no particular order. Those were just ones that that I just was trying to recall off the top of my head. But basically, what we're looking for is, can the patient move the extremity? Is there pulses in the extremity, and do they have sensation in the extremity? So Sometimes you'll hear people call that PMS, pain, movement, sensation, or excuse me, pulse, motor, sensation. I'm having a brain aneurysm tonight. Um, but we'll go back into the 6Ps again, and I'll give you a little bit more information about early signs and late signs as we move along. But that's how we would recognize a complication was occurring secondary to the extensive inflammation that the patient's experiencing. So again, we might get an X-ray if you've ever experienced a sprain or a strain. You may not have really done anything. You may not even have gone to an advanced care provider or a urgent clinic or anything like that, unless it was pretty significant. And pain, I think, is pain and decreased ability to bear weight is usually why people seek care. Um, but we'll get an X-ray. Basically, ask the questions about the story. What happened? What were you doing? Look and see, what the patient's activities were. Those types of circumstantial pieces of information are really going to be able to tell us probably what happened. The X-ray is really just going to rule out any kind of fracture or something of that nature. And if it is a really extensive injury, the patient may ultimately require some type of surgery. I don't know how often that occurs because of a sprain or strain, but it would definitely have to be some significant damage to that joint. And it does take time for these types of injuries to heal. It takes about 6 weeks before a tendon or a ligament or a muscle is strong again. And during that healing time, that, day 0, when we experience the injury up to that 6 weeks of time, during that healing time, that tissue is very vulnerable to re-injury again. So any stress that's placed on that injury could re-injure that, leading to excessive amounts of scar tissue, ultimately resulting in long-term range of motion and flexibility issues and long-term pain, things like that. So it can be really challenging sometimes for individuals who have experienced some sort of sprain or strain to not utilize that joint, because oftentimes the reason that they've experienced that injury in the first place is because of their normal activities. Maybe they're athletic, or my boys are runners, and so sometimes we see this. So it can be really hard for them to stay off of that injury, especially if they're starting to feel better. So just because it takes 6 weeks before that injured tissue is strong again doesn't mean that it's going to be 6 weeks that they're going to feel miserable. And so it's kind of hard sometimes for people to stay off of those injuries just because they don't feel bad, right? Once you start to feel better, you want to get back out there and get at it again. This is pretty basic first aid right here as far as nursing care for sprains and strains. And this is actually a really good picture of the anatomy of the ankle. Like I said, sprains or strains can happen in the wrist or finger or elbow, or in any place where you have ligaments and tendons, whatsoever. But it tends to happen a lot in the ankle. But you can see that there's lots of stuff inside of that tissue. And the other thing to remember about edema is there's only so much place for swelling to go. So like our muscles, they're wrapped in this fibrous connective tissue called fascia. And when a muscle is injured, right, like when a muscle is injured and it swells, it can only swell so much because it's encapsulated in this fascia. And that's just another kind of thing to keep in mind when you're considering those things like circulation and sensation and movement, or the compression of those other structures within the anatomy of the person's ankle. So the things that we do in response to that injury, we're trying to reduce the swelling. We're trying to control pain, make the patient more comfortable, but we're also really trying to reduce the swelling because, again, if that inflammation gets out of control, then the patient can experience complications. And so this may be very familiar to you. We call this RICE, rest, ice, compression, and elevation. So we recommend that the patient rest the injured extremity up to 72 hours, and this is going to allow the ligaments or tendon some time to heal. Ice is good. It can be applied but recommendations are for no longer than 30 minutes at a time, about 3 to 5 times a day for the first 24 to 72 hours after the injury. Ice promotes vasoconstriction, which is going to decrease bleeding and fluid collection in to the injured area. Compression oftentimes is done by means of an ACE wrap or some sort of other similar compression, like like ankle sleeves or whatever, some kind of compression device or dressing. And this is done to minimize further swelling, which can ultimately delay the healing. Now, we want to make sure that if this is something that we're doing, that the dressing is wrapped tightly, but not so tight that it's going to alter neurovascular function. So if we're using some sort of compression wrap, we still need to make sure that we're checking for circulation, for movement, and for sensation, because if those things become altered, then we may be cutting off, making the problem worse, right? Cutting off the circulation, cutting off the ability for those structures to do whatever it is that they do. So we have to make sure that's appropriate. Sometimes we have to loosen it if it's too tight. And then elevating the extremity, ideally above the level of the heart, but definitely so it's not in a dependent position, kind of dangling down. This too is going to minimize the amount of swelling that's going to occur. It just encourages the flow of blood kind of back towards the central circulation. We might also recommend NSAIDs like ibuprofen or I can never remember what that, naproxen. Those can be prescribed at higher strengths, or sometimes they can be purchased over the counter, but typically NSAIDs are pretty effective. Acetaminophen is always another analgesic. It doesn't have any effect on inflammation, but it can help with pain and discomfort. I don't know. I mean, I guess if it were really severe injury, the patient might be prescribed some kind of stronger analgesic, like an opiate or something like that. But Tylenol and ibuprofen are probably good. I'm going to grab a drink. I'll be right back. I've been using QuickTime to record my lectures so that I can put them on YouTube, and I haven't figured out how to pause it. And the last time I tried, it just stopped my recording and I had to start all over again. So pardon for the delay. All right, so let's move on and talk a little bit about fractures. Fractures is just a broken bone. Many people experience broken bones of all different ages. They can occur in young people. They can occur in elderly populations. We just talked about osteoporosis and how that increases the risk for fractures. So anybody who has some sort of comorbidity like that, like osteoporosis, bone cancer, other, different types of diseases, they're going to predispose the patient to being at risk um, for fractures. So another thing would be postmenopausal women. Again, we talked about that as it related to osteoporosis and how estrogen helps to, maintain strong bones. Um, so after menopause, women's bodies don't make estrogen at the same level, and so they're at risk for that. And then, of course, there's those high risk activities, like Evel Knievel. I don't know, he's probably broken, I don't know, has he broken every bone in his body? Do you guys even know who Evel Knievel is? But, football players, basketball players, contact sports, rugby, different things like that. So, any type of high risk activity is going to put you at risk um, for for a fracture. Now, what you see in this picture is something that it is a closed fracture. So you can obviously see that there is a deformity in that arm. So if we were to get an x-ray, we could probably guess that x-ray is going to tell me that there is a fracture, maybe in the radius, maybe in the ulna, maybe both. I don't know, by just looking at it, but our x-ray would be able to tell us that. But the reason that we call this a closed fracture is because there is no opening in the skin. So fractures can be closed like this, or they can be open. So this right here would be an example of an open fracture. Now, this is not very dramatic by any stretch of the imagination, but with this particular fracture, that humerus bone, when it was broken, it snapped in half and poked out through the muscle and fascia and adipose and skin, all those layers there, and then made its way back in. That's where that little hole came from, right there, just on the lateral side of the bicep. So when a patient has an open fracture, it does put them at risk for infection, because whenever the inside body of the world is exposed to the outside dirty world, then it can get bacteria and stuff like that inside and lead to infection. So when a patient has an open fracture, then we really have to be concerned about what's called osteomyelitis, which is an infection of the bone. So it's very common for patients who've had an open fracture to be prescribed antibiotics. Kind of because it's just assumed, I guess you could say, that is going to get infected. So, emergency management for a patient who experiences a fracture, you have to remember that oftentimes, not always, but oftentimes there are instances in which this fracture can occur in a very traumatic situation, be it a car crash, or I don't know, falling off a cliff, or getting thrown from a horse. I don't know, just it's going to be traumatic. So there could be other things that are um, underlying that may not be quite so obvious to our visual sense, that the patient is experiencing, that is going to affect hemodynamics. So really, I guess with any emergency management care, hemodynamic stability is always the priority. So we have to think about ABCs. If you think that if a patient's been in a motor vehicle crash and you're like, oh my God, look at this bone, like I can see it on the outside of the body, but the patient also has, a punctured lung, then the bone is really just secondary. So the hemodynamic stability doesn't really have anything to do necessarily with the fracture, but more so with the idea that when these fractures occur, it can happen in traumatic situations. And so we always have to consider the hemodynamic stability. So once all of that is under control and we feel good about hemodynamic stability and we're safe to start dealing with the fracture at hand, we want to immobilize the body part. When a bone has been fractured, if we don't immobilize and it's moving it around, it can cause internal structural damage. So bones are sharp when they're broken. They can be, and so they can cause pain to the patient when they're moving around. They can cause damage to blood vessels or nerves or muscles. So we need to immobilize the body part, and this is why oftentimes you'll see some sort of splint placed initially on a fracture, and the splint um, is placed proximally and distally to the fracture site, and it helps to support the fractured site and to keep it immobilized. Um, when when a I'm trying to let me think how to say this. When you have a fracture that is not immobilized, it can also increase the risk for something called fat embolism syndrome. So kind of tuck that one away for a minute. We'll come back to it. But another reason why we want to immobilize a fracture. Here's that word of the day again, neurovascular status. We want to make sure after we've immobilized it, we've splinted it, we want to make sure that the patient's neurovascular status is intact. So we're looking for signs and symptoms of pulses or perfusion, ability to move, and sensation. So if a patient has broken their humerus, do they have a good, strong radial pulse? Do they have good temperature distally to the fracture site? Do they have good skin color to distally from the fracture site? Are they able to move that extremity distally to the fracture site? Now, it might be painful, but it's still important to assess movement, because if nerves are compressed or maybe even severed to the point that a patient experiences paralysis, that could be a big, a really big deal. So those are the types of things that we're looking for. So here we go. Let's see if I can remember the 6 P's again. Let's see, pain, paresthesia, that means numbness and tingling. Paresthesia is often one of the earliest signs of neurovascular compromise. Let's see, we've got pain, paresthesia, pallor, that's paleness to the skin, it means we're not getting good blood flow. I'm going to keep going through these: pain, paresthesia, pallor, pulselessness, so an absence of pulse in the site distal to the fracture is going to mean we're not getting blood flow. That is a very late sign of neurovascular compromise. Pain, paresthesia, pallor, pulselessness, paralysis, inability to move. That again is a very late sign of neurovascular compromise. And what's the 6th one? Pressure. A little bit of pressure can be expected, but we need to be implementing interventions to help with that. So if that pressure doesn't go away, that pain doesn't go away with our interventions, then we could have bigger problems on our hand with something known as acute compartment syndrome, which we'll get back to that. So just tuck that one away. All right, so we kind of dove into I don't know why Siri just popped up. So we've kind of dove into what all those neurovascular things mean. If a patient experiences an open fracture, well, first of all, we never want to attempt to reduce the fracture, open or closed. That is outside of our scope of practice. That is something that will be done when a provider has had an x-ray, so they can kind of see the extent of the damage that's underneath that we can't see with our eyeballs. So we don't ever want to reduce that fracture. If a patient does have an open fracture, however, we do want to cover that just with a sterile dressing, just because, we want to try to keep anything out of that that we can't. So we're gonna do that. We do want to know how the injury occurred, and we kind of just went through, what if it's a motor vehicle crash or something like that. But there are lots of different ways in which injuries can occur. And if we start to consider like our marginalized populations, this is where this is really important for a unique reason of our consideration for abuse, right? So we want to know what happened, how did it occur, if it's a minor or maybe an elderly person, someone who is a vulnerable population, then that question might be asked to multiple parties involved. It might be asked of the patient, might be asked of the parents, it might be asked of the siblings or the caregivers or whatever, because they're trying to check for consistencies within the story. It's also going to tell us, are there other things that we need to be looking for as far as hemodynamics and that kind of thing? Let's see, what else might know it? Like where the force came from. So we just want to know what happened. Good physical assessment of our patient is, of course, going to start with that focused assessment. And so again, we're continuously monitoring for those 6Ps, those signs of neurovascular compromise. We'll get an x-ray probably right there at the bedside. They're pretty good at telling us about bony injuries, as I've mentioned. I guess it's possible that you might get a CAT scan if we need to see something a little bit more soft tissue. They're a lot quicker than an MRI and require less preparation. Pain control is going to be something that we need to manage. Pain control and inflammation. Remember, part of why a patient can experience neurovascular compromise is inflammation that's left unchecked. So if a patient has a fracture, it's highly likely that they're going to get some type of narcotic pain medication. A couple of things to consider here. It could be an oral pain medication, and that's fine. But it might also be an IV pain medication, and that's likely for a couple of reasons. Absorption is immediate, and so if the patient is really in a lot of pain because of this fracture, an IV pain medication is probably going to be the best to help control their pain. It's going to work very, very quickly. When a patient is not writhing in pain, distraught in pain, they're going to be. It's going to be much easier for them to be. I want to say be compliant, but that's not the word that I'm looking for. To cooperate, I guess, with the care that we need them to cooperate with. The other consideration with IV pain medication is, we have to think about what's going to happen with that fracture. Like, how is it going to be put back to where it needs to be? Because ultimately it does have to be reduced and fixed. And so if we think that a patient might be going to surgery, then an IV pain medication might be a good option for these individuals. Also, you might consider the element that anxiety is playing into overall pain control for a patient. And that might be, kind of an adjuvant therapy for somebody having a lot of pain. Maybe they were just in a very traumatic event, and controlling that anxiety might be really helpful in controlling the pain. We can use ice over the fractured site. We can try to elevate as much as we can just to help reduce the amount of inflammation that's going to occur. We can give Nsaids. There are actually IV Nsaids that we can give if we would want to explore that option. So lots of different things we can do there. There are pretty much two options for a fracture. There's a closed reduction and an open reduction. A closed reduction is going to be a non-surgical treatment of the fracture. This is probably the most frequent type of intervention that an advanced care provider is going to do for the patient. It's oftentimes when the fractured bone segments, there's not like a lot of shards or extensive damage. They can just easily kind of pull it back into place and get it to where it needs to be. So basically those bone segments are manually manipulated. or pulled on. Traction is applied, and then they're realigned. They can do this right at the bedside with the patient. It's nice to give them some sort of sedation, like a conscious sedation or something like that, to help with patient cooperation and pain. And then they'll put some sort of splint on it. Oftentimes, when they do a closed reduction, they put a temporary splint on the patient for about 24 to 48 hours, because they know that because of this injury, the patient is going to continue to experience inflammation. And a splint, it's basically like these two pieces of like material that gets really they usually have to submerge it in water, it gets wet, and then they'll mold it to like the top and the bottom of the fracture site, so that it supports the whole length of the fracture, and then they'll wrap it in like a big ace wrap. So there's really only something that's supporting the fracture site on the top of the bottom, and then it's being held in place by an ace wrap. And as I was saying, the reason for that is it is going to allow to be expanded, right? Because that ace strap is stretchy and pliable, and I don't have something completely encompassing the extremity. So if there is inflammation, it's going to allow for expansion and edema to occur as is expected. Uh, Once we've allowed those 24, 48 hours, whatever, to go by, and we feel like the edema is under control, then the patient will likely be placed into some sort of cast. Casts are going to completely encircle the extremity, and so because of that, there's not going to be as much room for expansion. And again, that's why we wait to place that on there, so that swelling can take place if necessary. Now, an open reduction is basically surgery. And what's going to happen there is the patient is going to go to surgery, and they're going to either do what's called an open reduction with an internal fixation or an open reduction with an external fixation. The internal and external really just refers to the location of the hardware that is placed during the surgery. So if it's an internal fixation, then there's going to be pins or plates or screws that are on the inside of the body that are holding the bone in place, and then they will close everything back up, and the patient will have just basically an external incision. If it's an external fixation, then there will probably be like pins and screws and plates and things like that, but they're held in place through a device that is placed on the outside of the skin. Patients who have external fixation are at risk for osteomyelitis because of the holes that are in the skin that are used for the external fixator to kind of hold the internal plates and things like that in place. So you have a direct opening from the outside to the inside. So external fixation is going to increase the risk for osteomyelitis. This is an example of an external fixator. People can actually get up and move with these. I haven't worked with them very often. I've never been one to be an orthopedic nurse, but I have seen a couple of them on the leg, or on the arm, I think is where I saw them. But underneath all of that gauze wrap, there's a place where that actually goes in and holds on to part of the bone so that it can kind of stay in place, so that it's then allowed to heal. Again, the nurse is going to be doing those neurovascular assessments, making sure that there's good pulses and good signs of perfusion, evidence of movement and sensation distally to the injury. But we're also going to be monitoring this patient for infection, because we know that they have this external device that puts them at risk for infection. Now, this would be an example of internal fixation. You can see the x-ray image here on the left, where there are plates and screws that are holding the pieces of the bone into the place that they need to be held, so that the bones can then start to heal. And then on the right side of this picture, you kind of see what that looks like um, surgically. So same kind of thing. We're using medical, devices to hold the bone fragments in place so they can heal. Just one of them is an internal approach, and the other is an external approach. Now this here, what you're looking at is something called traction. This doesn't fix a bone, but it does help to provide a few things for a patient who has experienced a fracture. Especially see this in fractures of the leg where we apply traction. This particular type of traction that you're seeing here is something that's called hair traction. And this is a very temporary form of traction that's placed on the patient, usually in out in the field, like the medics will place this, or sometimes I've seen it put on down in the emergency department, but it's very temporary. The purpose of traction is to reduce that fracture, so kind of pull it out and put it back into place so that the bone is realigned. This is going to promote healing of the fracture. It's going to reduce the potential for mobilization of that fracture. Ultimately, that movement not stabilizing that fracture could lead to fat embolism syndrome. It's going to provide some relaxation to that muscle, because you have to remember, if we have a fracture in the femur, it's a pretty big bone, some pretty significant muscles in our quads and our hamstrings. If that bone breaks, it can be pulled, just slide right on top, like one part right on top of the other, and those muscles can spasm quite severely and cause a lot of pain. So if we pull those bones back out into place, then it's going to help promote that comfort, prevent soft tissue damage, maybe prevent deformities, allow for rest of that tissue, and just overall, promote comfort in the patient. Now, there are a couple of different types of traction. The one on the left is something that's called skeletal traction, and if you look closely just above the knee, there's that gauze pad there. Basically, what has happened here is they have drilled in like these pins into the distal part of the femur, one on each side, and then they are using a force of that machine that's at the bottom of the bed. It's not a machine, it's like a weight and pulley system to pull that bone so that it stays aligned. So a little bit different than hair traction, but again, not really something that's meant for long term. Hopefully this patient will be able to go into surgery and they can put rods in there and kind of fix that. The one on the right hand side is something called skin traction. There is nothing like drilled into the bones or anything like that, but basically we have these supportive pieces or splint like things that are around the medial and lateral aspect of that leg. It's wrapped in like an ACE or Coban or something of that nature, and a weight and pulley system is pulling on that contraption that we've created, that splint contraption, and providing the traction necessary to keep the bones in line. Weights and pulley systems like this, they need to be hanging freely because there is a prescribed amount of weight that is placed on that device according to whatever the provider tells you to put on there. We can't just lift up the weights and release the weight on that traction, because then you're going to get the bone out of alignment. So this can be really tricky, and then care of the patient from the perspective of the nurse when it comes to moving the patient and things like that. It has to be a really coordinated effort. We should never have the weights lying on the floor, because then it's not going to be providing the traction. The pulleys shouldn't just be hanging over the edge of the bed. That's why you can kind of see them kind of, lifted and suspended over a specific thing that it's meant to be that way. So just some basic things about traction for your patient. Now, this is anatomy right here. This isn't anything that I'm expecting you to memorize, but just more so that I just want you to see the process that it takes for a fractured bone to heal. There's a specific way in which the body heals a bone and processes that it has to go through, and how it has to then form a new bone and heal that fracture. And ultimately, that can take up to a year. Very similar feeling, as I would imagine, as the person who maybe experienced a sprain or a strain. They start to feel better, but that doesn't mean that they are ready to get back out there at 100%. So same sort of idea with a fracture. It can take up to a year for a fracture to really be healed. And during that healing time, that fractured location is at risk for re-injury. So just some food for thought there. All right, let's talk a little bit about complications related to fractures. Now, some of these are new. Some of them we've kind of started talking about here in this lecture, and some of these we've seen before. So we got a nice little mix of complications. So first one is something called Compartment Syndrome. Compartment Syndrome is a very serious complication that, if it is not detected, can lead to permanent loss of function or even of the actual limb that is affected. Patients who have or are developing compartment syndrome might complain of pain or passive pain when there is at rest. When the extremity is at rest. So they're having a lot more pain than what is consistent with the injury. Excessive pressure in the extremity, paresthesia, numbness and tingling, pallor or pale skin, paralysis, not able to move it, pulselessness, so our neurovascular compromise, really signs of neurovascular compromise. Pallor, paralysis, and pulselessness are late findings. So if your patient with a fracture begins to complain, of passive pain, of paresthesias, we really need to start reaching out and letting the provider know about that. Ideally, we can prevent compartment syndrome before it even occurs by implementing interventions to promote to decrease inflammation, is what I'm saying. But once the patient starts to develop compartment syndrome, elevation of the extremity, something that we do, right, to reduce inflammation, is no longer a viable option, because with compartment syndrome, because of what is happening inside of that compartment where the fascia is wrapping the muscle, in compartment syndrome, those vessels, blood vessels, are being compressed. If we lift the extremities to try to fix compartment syndrome, we're only compromising blood flow to the extremity even more. Because when they're starting to experience compartment syndrome, we need to encourage blood flow to the extremity, so we don't want to elevate the extremity. So way before they develop compartment syndrome, we want to prevent inflammation altogether. But once they start to develop compartment syndrome, then we have to promote blood flow to that area. Sometimes we even have to have the patient go to surgery and have what's called a fasciotomy, and I have a picture of that somewhere coming up. I think I do, yeah. On the next slide, I'll show you where basically what happens there is incisions are made on the medial and lateral side of the extremity, and the fascia is cut open, because remember, it's the fascia that has created the compartment around this muscle that's preventing it from swelling out. So when we go in and we cut that fascia, it allows the tissue, the muscle, to continue to swell and expand. And then until that swelling goes down, then that would be just a big old open wound. Here, look at this. There you go. You have pictures. This is actually a friend of Mrs. Riddle's, who gave me permission gave her permission to give me permission to use these photos. I don't know who this person is. Now, they didn't have a fracture, but they did experience compartment syndrome. But you see how on the lateral side of the leg, this picture on the left, there's that large incision where they've cut open through the skin, through the fascia to allow that muscle to swell. And here on the right-hand side, that medial side of the leg, they've cut open the skin through the fascia and they've exposed the muscle to allow that muscle to swell. Now, once that swelling is gone and is starting to subside, then those incisions would then be closed up. So probably very anxiety provoking for your patient, probably high risk for infection, that kind of thing. Now, another thing that can cause compartment syndrome is a cast. So if a patient has a cast on, then they're going to have the cast removed, because remember, the cast is completely surrounding the circumference of that extremity, so it's not going to allow pressure and swelling to go outward. It's going to encourage pressure and swelling to go inward and compress all those vessels. So if they have a cast, then we might have to do what's called bivalving the cast, which basically is cutting it down both sides and essentially making it a splint, then wrapping it with an ACE bandage. And those are things that we wouldn't do independently. We would be communicating with the provider and making sure that those things got done. So we've kind of talked about neurovascular compromise as part of compartment syndrome, but it doesn't occur exclusively with compartment syndrome. We can have neurovascular compromise without compartment syndrome. It is also a complication because of the risk of sharp bone fragments created by fractures, which can lead to severing of the blood vessels and nerves that surround the bones. So again, those 6 P's are what we're looking for. Early signs of neurovascular compromise are paresthesia, whereas late signs, of course, would be, what did I say late signs were? I don't want to tell you wrong. Pallor, paralysis, and pulselessness. If we get to that point, those are late signs of neurovascular compromise. Venous Thromboemboli, this is a DVT, basically, is what's happening there. We've talked about DVT when we talked about perioperative care. So these blood clots are developing in the large vessels of the extremity, primarily because of extended periods of immobility, also because of traumatic injuries, long surgeries, smoking, oral contraceptives. We've talked about lots of the risk factors that a patient might have for the development of things like DVT. And so when we can, we want to prevent DVT in our patient by utilizing things like early ambulation, SCDs, TED hose, pharmacological anticoagulants, so like Lovenox or heparin. Those things are going to help our patients to prevent DVTs. The thing with a DVT is if a patient does experience a DVT, that blood clot can break off and travel to the pulmonary vasculature, where they can experience signs and symptoms of pulmonary embolism. Again, we talked about that when we discussed perioperative care. Chest pain, sudden onset of shortness of breath, feelings of impending doom, tachycardia, hypotension. Those are all signs of pulmonary embolism. So we want to prevent DVT if we can. Now, if a patient has a fracture in the left lower extremity, of course, we cannot put an SCD on the left lower extremity, but we could on the right lower extremity. If they had fractures on both of their lower extremities, then we just know that that patient is going to be at a really high risk for DVT, right? And we have to implement pharmacological intervention and have astute monitoring so we can detect those problems quite early. Fat embolism syndrome is actually a very rare complication that can occur after orthopedic injury or surgery, especially an injury to a long bone. We often see pulmonary dysfunction first. The patient is feeling short of breath, so they have tachypnea. dyspnea, hypoxemia. Then they might start to experience cerebral changes. So you might notice acute confusion, maybe some drowsiness, ultimately, maybe even as severe as a seizure type of activity or even coma. They can sometimes, or you can see also what's called a peticule rash located in the chest and axilla or in the conjunctiva and on the neck. And a peticule rash is like a little pinpoint dotted rash that's not raised. So it can look very similar to some of the signs and symptoms of pulmonary embolism, but we do have some differentiation there with the cerebral changes and the peticule rash. The best thing to do for fat emboli is to reduce the risk by immobilizing fractures. But of course, if a patient does experience fat emboli, it's really just supportive care. There isn't anything that we can really do for it necessarily. We're going to, support the ABCs. They'll probably be placed on anticoagulants if they are not already, supporting oxygenation and ventilation and things like that. Thank goodness it's a rare condition. Rhabdomyolysis, this is something that happens when we have ischemia, in other words, death of tissue, and it's muscle tissue. And so when we have a fracture, that can happen because just of the nature of the injury, especially if we have some type of fracture related to a crush injury or something like that. We have all of this release of not just cellular contents like potassium and that kind of thing, but also just the destruction of those muscle cells can lead to a release of proteins into the bloodstream, and those can kind of clog up the kidneys. So a patient can experience acute renal failure. They can have something like a flank pain that's kind of around your back there where your kidneys are at, dark tea-colored urine, general like severe malaise and fatigue and just not feeling very well at all. Also, the elevated potassium, of course, the low phosphorus, high calcium levels. Those are all types of electrolyte disturbances we might see. When a patient has rhabdomyolysis, we are monitoring, what's the name of that lab? Hold on. CPK. We're looking at something called CPK, that stands for creatinine phosphokinase, and we will trend that over a period of time. It'll get really, really high, and as we start to treat the rhabdo, it will start to come down. And really, the best way for us to treat rhabdomyolysis is dilute IV fluids. These patients are going to get high rates of IV fluids, high volumes of IV fluids, which is going to put them at risk for hypervolemia. So we want to monitor that. And we also want to see that their kidneys are working. And so we're going to closely monitor these patients' urinary output. Not all patients who have rhabdomyolysis will have a urinary catheter, but it is something that I see commonly because we do really want to strictly monitor the patient's urinary output because of the injury to the kidney. Hypovolemia, we know what this is. We've talked about hypovolemia before, and this is going to be in the instance of a fracture related to blood loss. There might be some internal bleeding or otherwise. And then lastly, it is not on the slide, but just want to make note of it, is infection is another complication of a fracture. Oh, we looked at that one. This is some pictures of some casts that you might see on a patient. A couple of things just to kind of keep in mind is that when a patient has a cast on, it's going to add extra weight to that extremity, and that's going to kind of pull other muscles and things like that kind of out of alignment. It may cause someone to walk a little bit different. It could cause stress on areas of the back or pull down the shoulder muscles, things of that nature. But it's still going to be uncomfortable for a patient to have a cast. Again, here we are with the neurovascular status. When a patient has a cast, we need to be assessing the neurovascular status. Those 6Ps, can they move their fingers or wiggle their toes wherever their cast is at? Any numbness or tingling, what kind of capillary refill, what kind of pulses are present. So we're monitoring that. We're also monitoring for pain. It is expected when patients have a fracture for them to experience some pain, but if it starts to be pain that's inconsistent with the injury that they've experienced, that might be something that we need to prick our ears up about. That could mean that we're starting to see some neurovascular compromise. We also want to make sure that we're checking the condition of the cast. These things can get kind of rough and bumpy. They do put cast padding underneath to help protect the skin, but we do need to monitor the skin for signs and symptoms of tissue integrity or tissue irritation, especially around the edges of the cast, just kind of watching that skin. It can get kind of itchy underneath of there, or so I'm told. We want to make sure that our patients do not stick anything down in the cast, like a ruler or a pencil or anything of that nature, to itch and scratch, because that can impair skin integrity underneath of the cast, which would be very difficult for us to detect, and then it could become infected. Elevate the extremity for 24 to 48 hours. We can put ice bags on the outside. Again, those are going to help with inflammation. As time goes on, when a patient has a cast, it's also not uncommon for them to have multiple casts. As the swelling kind of continues to subside and the injury heals, they may have one cast taken off and it becomes really loose, which is ineffective, and they'll have to go in and have another cast placed instead. Exercising, really what I'm talking about here is like encouraging blood flow to the extremity. So, doing hand exercises or foot exercises just to help increase blood flow back up to where it's supposed to be. I think I just kind of talked about all of those sorts of things. Like, we're learning here in this class, about neurovascular compromise and what that looks like in our patient. So these are things that we can also teach our patients when they need to call the provider for further intervention. Very quickly about dislocation, this actually is a medical emergency. Any joint can be dislocated, and this is when the bones that form the joint kind of come separated from one another. I always think of shoulders when I think of dislocation, although I have seen a hip or two get dislocated before as well. It's very common with physical contact sports, things like football, soccer, rugby, that sort of thing. And it is very painful. The goal of the treatment for dislocation is to get the bones back where they belong so that we don't prevent damage to the surrounding tissues. This is typically done under conscious sedation. So like with the shoulder, they might just give a little bit of fentanyl and Versed, and then the provider reduces the dislocation back to where it needs to be, and then they will immobilize the joint. It is important for the joint to remain immobilized because those tendons and ligaments and things have gotten stretched out because of the dislocation of that bone kind of coming out of socket. So we want them to kind of rest that. So a patient, like for a shoulder dislocation, might have something called a sling. You might know what that is. Kind of helps to support the weight of that extremity off of that shoulder joint to reduce the pain. A lot of times, though, the pain is pretty much gone once we get it back into the socket, at least for now. It's quite likely that they will experience pain in the extended period, but in the initial moment, it's usually much reduced. The pain is once the shoulder is actually reduced. This is another one that we need to check neurovascular assessments on our patients to make sure that there hasn't been any compromise to structures such as blood vessels, nerves, that kind of thing. Osteomyelitis. This is nothing new to us. We have talked about infection before. In this particular instance, we of course are talking about infection of the bone. There are certain individuals who tend to be more likely to develop osteomyelitis, such as open fractures, as I mentioned previously, or other types of orthopedic surgery, patients who have diabetes, patients who are older aged. It's really kind of difficult actually for a bone to get infected. They're pretty well protected. So when it does get infected, it is very difficult also for it to heal. It's very challenging to get the antibiotics to be able to get to the site so that the bone can heal. It can be because of a bone fracture that might be called exogenous osteomyelitis. It can occur because of a bloodstream infection, and the infection kind of seeds itself into the bone. That's called endogenous osteomyelitis. Or it could be because adjacent skin infection, like with a neuropathic or a diabetic ulcer, has kind of burrowed through and started to infect the bone. That's called contiguous osteomyelitis. Once bone necrosis occurs, healing is delayed, abscesses can be developed. Staph is a really common pathogen for osteomyelitis. We can see pain that's not relieved by rest, swelling at the site or near the site where the bone is infected, tenderness, warmth, and of course those are system-specific signs of an infection. And then we also think about systemic signs of infection being things like leukocytosis or evidence of inflammation by looking at ESR and CRP. MRIs are used quite a bit to help in the diagnosis of osteomyelitis. They can see if there's infection present around the bone, necrosis of the bone, that kind of thing. But truly, a bone biopsy is the definitive way to know that a patient has osteomyelitis. Sometimes patients do have to have digits or pieces of their bone and surrounding structures amputated. Other times, medications will work, and by medications we mean antibiotics. If a patient has osteomyelitis, it's very common for them to have IV antibiotics for an extended period of time, usually anywhere from 4 to 6 weeks or 6 to 8 weeks. So it's a long time that they're going to get IV antibiotics. Sometimes they can get it to where the antibiotics are only once a day, and a patient can go home and then come to like an infusion center every 24 hours and get their antibiotic infusion. Other times patients might have to go to some sort of rehab facility. Maybe it's, the antibiotics that are working require multiple times a day dosing. Also very likely, if a patient has osteomyelitis, that they're going to need some sort of central line, most likely a PICC line, because we know that the antibiotics are going to be required for such an extended period of time. This is what is called antibiotic bead placement. You can see that these little beads here are directly placed into the tissue with the bone. So something a little bit different. I don't know how common that is, like statistically speaking, but I do know that I've seen that in more than one patient. It was something that one of the docs around here did quite a bit with his foot patients. Okay, carpal tunnel syndrome is something that can occur, an injury that can occur because of repetitive movement it's like the same movement over and over and over again for a long period of time. I guess that's what repetitive means. So this is something that is really common in like factory workers, because factory workers will do the same exact task like over and over and over again. maybe people who play instruments with their hands, um, typists, people that are typing a lot, they're using those muscles in their hands. Basically, this space in your wrist, this carpal tunnel, because of the excessive use of that muscle, starts to cause inflammation in that place, in that space, inflammation of the tendons and the ligaments, and then all of that inflammation compresses on the nerves and the tendons and the ligaments, and it starts to cause pain and discomfort and decreased strength and things like that. So the older you are, the more likely you are to develop carpal tunnel syndrome. Of course, there are certain types of employment, as I had just mentioned, where we have repetitive motions of the hand. Women are more likely. Pregnancy increases your risk if you've had trauma to that location. Another risk factor there. So patients will experience sharp pain, numbness, and tingling. Oftentimes, one of the first things that they notice is that they're woken up at nighttime from like a dead sleep with this pain that's in their hand. So that's oftentimes a first kind of sign. But then it kind of gets worse over time. It's progressive. As a person is participating in whatever the activity is, they're having a lot of pain. And then once they stop and kind of rest the hand, then the pain starts to kind of go away. So how does a provider diagnose this? Well, really it's basically patient history. They're looking at the risk factors and the signs and symptoms that the patient is actually experiencing. They may do some nerve study tests or look at the tissues with an MRI or ultrasound or something like that, just to kind of see how severe the damage is or what it is they're actually dealing with. They may get a cervical spine x-ray, and the reason for that is because there are nerves that kind of start up there in the cervical spine that could lead to similar symptoms down the arm. So they might start with that to make sure, more of like a rule out sort of thing. There are a couple of tests that they might do. I don't know like how 100% accurate these are in diagnostic purposes, but the one on the left is a Phalanx test. That might be just a quick assessment that they do in the provider's office, and when a patient does this, they will experience shooting pain from the wrist. Nope, just kidding. When a patient does a Phalanx test like this, after a minute, 60 seconds, they will have numbness and tingling and weakness in their hands. With the Tinel sign, they experience shooting pain from the wrist when you're tapping over the medial nerve. So as you're sitting there testing yourself to see if you have carpal tunnel syndrome, I will move on and talk about some of the treatment. So really, we need to get rid of the repetitive motion treatment. So this could be finding a different job. Sometimes that can be very hard if that's the only job that you can't just up and leave your job if you don't have something else to go to. Sometimes we can modify the work environment. Ergonomics was a big thing. We changed a lot of the ways that we sat at like computers and how keyboards were made, and in factories, like changing up the work that you do so you're not always doing the same part on the line. So those are some things that we can think about. Nsaids are going to help with inflammation. Of course, Tylenol is an analgesic to help with discomfort. Steroid injections would be like a shot that's directly into the tissue. It's going to help locally to reduce inflammation. These that tend to work pretty well for inflammatory problems, like in spaces like this, or if we're talking about joints for arthritis. But it's not a fix. It doesn't fix the problem. It's just going to provide some comfort and kind of help with the pain for a short period of time. Night splinting might be something that a person does where they just basically wear a supportive splint at night that holds their wrist and hand kind of in a position to keep it from becoming more irritated and to give a little bit of rest. Some people do have carpal tunnel surgery. It's called carpal tunnel release, where they go into that space, the carpal tunnel there in the wrist, and they cut the ligament in there to enlarge the space. It doesn't always fix the problem, but oftentimes it does. And that approach can be through an open type procedure or an endoscopic procedure. As far as like the size of the incision, I mean, I don't think there's really much difference. So I don't know if there's a preference for that. I've not cared for anybody personally, but otherwise, post-operative care is really going to be just like any other post-operative care patient. I imagine these individuals will have outpatient surgery and probably not stay in the hospital with a surgery like this. So this would probably be somebody that you follow up with the community. They'll need physical therapy, pain management, education about signs and symptoms of infection, and sort of that sort of thing. Like I said, it doesn't always work. Sometimes patients can have loss of sensory and motor and function after they've had a carpal tunnel surgery. They can experience mobility issues in the hand and the wrist for long term, and they can also still continue to have pain. So I guess it's worth a shot. That is all that I have for you in installment number 2 of our mobility lecture. As always, if you have questions, please do not hesitate to reach out and get those things clarified.